الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Varicella and Varicella vaccine by Mahmoud Hani Sulaiman, Professor of Community Medicine. First of all, we'll talk about congenital infectious disease, the so-called TORSH, TORSH. These are toxoplasmosis, other, rubella, cytomegalovirus, herpes, and syphilis. Toxoplasmosis, others include HIV, parvovirus, varicella, listeria, TB, malaria, and fungi. Rubella, cytomegalovirus, herpes, and syphilis. So varicella is one of these congenital infectious diseases. Varicella zoster virus. Herpes virus DNA primary infection will lead to chickenpox. Recurrent infection will lead to shingles. Short survival in environment. Pathogenesis, respiratory transmission of virus, replication in nasopharynx and regional lymph nodes, repeated episodes of viremia, affect multiple tissue, including sensory ganglia infected during viremia. Pathogenesis. Virus enter respiratory conjunctiva and go to lymphoid system. يبقى virus enter respiratory system and conjunctiva and go to lymphoid system. After incubation 2 weeks, virus arrives at main target in skin. Following primary infection, virus remains latent in cerebral or post-root ganglia. In 20% of cases, a single recurrent infection occurs after several decades. Virus reactivates in ganglion and attacks down sensory nerve to area of skin supplied by it, which will lead to varicella form of rash in distribution of dermatome. Epidemiology. Primary varicella is an endemic disease. It is one of classic diseases of childhood with highest prevalence occurring in 4 to 10 years of age. Varicella is highly communicable, attack rate 90% in close contacts. Most people become infected before adulthood, but 10% of young adults remain susceptible. Herpes zoster occurs sporadically and throughout the year. Epidemiology. Reservoir, human transmission, airborne droplet with direct contact with lesions, seasonal pattern, peak in winter and early spring, communicability 1 to 2 days before to 5 days after onset of rash. So 2 days before to 5 days after onset of rash. May be longer in immunocompromised. Clinical features: 14 to 16 days, mild prodrome for 2 days, rash appear first on head, most concentrated on trunk, less on face, scalp, limbs, and mucous membranes of mouth, maculopapular, then vesicular, and progresses to crusted lesions in 5 days. Successive crops 2 to 4 days of pruritic vesicles. Primary infection will lead to chickenpox, presence with fever, lymphadenopathy, a widespread vesicular rash, diagnosis on clinical grounds alone. Complications rare but more frequent with greater severity in adults. It is severe in adults, immunocompromised patients. Most common complication is secondary bacterial infection of vesicle. Severe complications which may be life-threatening include viral pneumonia, encephalitis, and hemorrhagic chickenpox. This is the varicella rash. On the left side, classical case. On the right side, complicated infected case. This is chickenpox in a child. This is in an adult. It is severe in adult. Complications: bacterial infection of lesions, CNS manifestations, pneumonia, aseptic meningitis, encephalitis, Rice syndrome. It is important. Again, here we say Rice syndrome. Fatty infiltration and dysfunction of liver, acute encephalopathy in these patients, especially children, if they take aspirin to reduce fever in such a disease. Hospitalization around 3 per 1,000, death around 1 per 60,000 cases. Groups at increased risk of complications: healthy adults, immunocompromised, newborns of mothers with rash, onset within 5 days before to 2 days after delivery, newborns of mothers with rash, onset within 5 days before to 2 days after delivery. Herpes zoster occurs due to reactivation of varicella zoster virus. Reactivation of varicella zoster virus associated with aging, immunosuppression, intrauterine exposure, varicella at less than 18 months of age. Herpes zoster shingles mainly affect single skin dermatome, occurs at any age but mainly more than 50 years. The latent virus reactivates in sensory ganglion and tracks down sensory nerve to the supplied dermatome. A characteristic eruption of vesicles in dermatome with intensive pain, which may last for months. Herpes zoster affecting eye and face is a great problem. In immunocompromised, herpes is a great problem because reactivation occurs earlier in life and multiple attacks occur as well as complications. Complications rare, including encephalitis and disseminated herpes. This is a case of herpes zoster involving the lumbar dermatome. Antiviral therapy of varicella zoster infection. As you see, there is multiple drugs: acyclovir, valaciclovir, famcivir. All these can be used. Each one is used for a special disease. For chickenpox, acyclovir. For chickenpox in immunocompromised, acyclovir. Herpes zoster, you may use valaciclovir, famcivir, and acyclovir. Herpes zoster in immunocompromised, acyclovir, valaciclovir, famcivir. And this is the dosage. Please print this table and use it in your clinic. Congenital varicella syndrome results from maternal infection during pregnancy. Occurs due to maternal infection during pregnancy. Period of risk may extend through first 20 weeks of pregnancy. Clinically, low birth weight, atrophy of extremity with skin scarring, eye and neurologic abnormalities. These are variety. Risk appears to be small, less than 2%. In third trimester, maternal varicella may lead to premature labor. Primary infection of congenital varicella is rare during pregnancy because 90% of pregnant women are already immune. Primary infection during pregnancy carries a greater risk of severe disease, in particular pneumonia. Susceptible pregnant women exposed during pregnancy should seek specialist of obstetric advice. They can afford varicella zoster immunoglobulin and antivirals. and these again are the antivirals, especially when delivery is imminent. When chickenpox develops in pregnancy, early medical review within 24 hours of rash onset is indicated to consider treatment options. Healthcare workers, what to do in case of chickenpox and varicella. Pre-placement healthcare workers with an uncertain history of varicella, they must be serotested and offer vaccine if susceptible. If rash develops in 3 weeks after vaccination, healthcare worker removed from patient contact until varicella is excluded or lesions have crusted. If HCW exposed to confirmed varicella or HZ, he may contact patient if they have a history of previous infection or immunization. HCW advised to report any fever or rash developing within 3 weeks of exposure and do the above mentioned in 2. If HCW is susceptible and exposed, vaccine in 5 days of exposure. Vaccine in 5 days of exposure is indicated. They should report rash occurring in 6 weeks of vaccine and do what is mentioned in 2. If vaccination is refused, no patient contact should take place between days 10 to 21 after first exposure. Shingles in healthcare workers. Workers should not care for high-risk patients until lesions have crusted over. Other patients can be cared for as long as lesions can be adequately covered. Neonatal varicella. This virus can cross placenta in late stages of pregnancy to infect fetus congenitally. Neonatal varicella may vary from a mild disease to a fatal disseminated infection. If rash in mother occurs more than 1 week before delivery, then sufficient immunity were given to the fetus. Zoster immunoglobulin given to susceptible pregnant women who had contact with suspected cases of varicella. Zoster immunoglobulin also given to infants whose mothers develop varicella during last 5 days of pregnancy or first 2 days after delivery. Case management. Uncomplicated varicella is self-limited disease and requires no specific treatment. Acyclovir accelerates resolution and prescribed by some doctors. Acyclovir should be given promptly to immunocompromised with varicella infection, normal individuals with serious complications as encephalitis. The main problem is management of post-herpetic neuralgia. All patients more than 50 years presenting with herpes zoster should receive antiviral therapy, either acyclovir, valcyclovir, or famciclovir. General measures for case include calamine lotion, tepid bathing or cool compress help to alleviate itching, exclude from school till cured or at least 5 days after eruption first appears, advise adults to stay away from work for the same period, avoid contact with increased susceptible, aspirin never given to children with varicella because it may lead to race syndrome. Control of contact. Significant contact defined as face-to-face contact for at least 5 minutes, being in same room for more than 1 hour, or household contact. This should be given vaccine in 4 days. And varicella zoster immunoglobulin, look after details. Zoster immunoglobulin is drug of choice, expensive if it is not available. Human immunoglobulin should be given instead. Considered for individuals at risk of contracting severe varicella infection, e.g., leukemic children, neonates, and pregnant women, immunosuppressed persons. Vaccine data suggests that vaccine is safe even in children with leukemia, provided that that they are in remission. Varicella vaccine composition: live attenuated virus, efficacy 95%, duration of immunity more than 7 years, schedule 1 dose for those who are less than 13 years. MMRV, combination of measles, mumps, rubella, and varicella, approved children 12 months up to 13 years. Titer of varicella vaccine virus in MMRV is 7 times higher than standard varicella vaccine. In children at 1 to 1.5 years, recommended for all children without evidence of varicella immunity by the 13th birthday. Adolescents and adults, all persons more than 13 years of age without evidence of varicella immunity, 2 doses. If he is more than 13 years, 2 doses and separated by 8 weeks. Do not repeat first dose because of extended interval between doses. Vaccination of healthcare workers recommended for all healthcare workers. This is clear. All healthcare workers, medical students are healthcare workers. Post-exposure prophylaxis, 70 to 100% effective if given within 72 hours of exposure, not effective if after 5 days. Adverse reaction of varicella vaccine: injection site complaints, rash, systemic reactions not common. Contraindications and precautions: allergy, immunosuppression, pregnancy, acute illness, recent blood product. Varicella zoster immune globulin may modify or prevent disease if given within 96 hours after exposure. Indication: immunocompromised persons, newborn of mothers with varicella virus infection, 5 days before to 2 days after delivery. Premature infants with postnatal exposure, susceptible adults and pregnant. If supply of varicella zoster immunoglobulin decrease, use intravenous immunoglobulin or acyclovir. وفي النهاية لا أجد إلا أن أقول الحمد لله رب العالمين و thank you for your listening.